In this lesson, we'll discuss urinary tract injury. There are 5 parts in this lesson, including introduction, renal injury, ureter injury, bladder injury, and urethral injury. Urological injuries only account for a small percentage of all injuries, but are responsible for both mortality and long-term morbidity. Various kidney injuries can cause acute hemorrhage and can be immediately life-threatening. Lower urinary tract and genital trauma may lead to lifelong disability and impaired quality of life. The first is renal injuries. Renal injury can be classified into penetrating and blunt injuries. Penetrating injuries often caused by a sharp instrument, such as a knife or a bullet, making a penetrating wound in the chest or abdomen. Blunt injury is usually caused by a direct violent hit on abdomen, loin, or indirect force by falling from a high place and landing on the feet or buttocks. This table is the American Association for the Surgery of Trauma Organ Injury Severity Scale for the kidney. In this system, renal injury is classified into 5 grades. In China, renal injuries are usually classified into 4 types: contusion, partial laceration, complete laceration, and injury of renal pedicle. In contusion, there is only subcapsular hematoma. Partial laceration represents the laceration in parenchyma without collecting system rupture or urinary extravasation. Complete laceration means the laceration extending through renal parenchyma and collecting system. Injury of renal pedicle denotes the major renal artery or vein injury. This figure is the classification of renal injuries by grade based on the organ injury scale of the American Association for the Surgery of Trauma. The patient with renal injury might have shock, hematuria, pain, ecchymosis, abdominal and flank mass. When infection occurs, the patient may have fever. Shock implies persistent severe bleeding. The degree of hematuria and the severity of the renal injury do not consistently correlate. The diagnosis can be determined based on the history of injury, physical examination, laboratory test, and imaging examination. Laboratory examination should include blood analysis, blood urea, and creatinine level. Sonography is usually used in the immediate evaluation of injuries, facilitating the rapid diagnosis of intra-abdominal injuries. Contrast-enhanced CT is the gold standard for genital urinary imaging in renal trauma. Contrast extravasation, parenchymal, and vascular injury can be clearly demonstrated. Excretory urography has been replaced by the CT scan. In selected cases, renal arteriography can be considered an adjunct diagnostic imaging technique with possible therapeutic implications. MRI is not usually used for the diagnosis of renal injury. Conservative management is the standard of care in hemodynamically stable patients, including strict bed rest until gross hematuria disappearance, surveillance of vital signs, abdominal mass, hematuria, hematocrit, blood transfusion, hydration, maintenance of electrolyte equilibrium and urine volume, prophylactic antibiotics, analgesic, sedative, and hemostatic agents. Indications for renal exploration include penetrating injury, blunt injury such as severe laceration, shattered kidney, and renal pedicle injury, hemodynamic instability with shock, persistent gross hematuria, dropping hematocrit, expanding renal hematoma. Renal injury together with intra-abdominal organ injuries and uretero-pelvic junction disruption. Surgical management consists of renal reconstruction, partial nephrectomy, and nephrectomy, which should be selected according to the severity of injury. The second is ureteral injury. Ureteral injury can result from external trauma, radioactive trauma, open surgery, laparoscopic and endoscopic procedures. Ureteral injury compresses contusion, perforation, laceration, dehiscence, incision, torsion, ligation, transection, and ischemic necrosis. Unrecognized or mismanaged ureteral injury can lead to significant complications, including urinoma, abscess, urethral stricture, urinary fistula, and potential loss of an ipsilateral kidney. If ureteral injury is caused by endoscopic procedures, there might be hematuria. Urinary extravasation may present with the signs of peritoneal irritation and fever. Urinary fistula usually occur 1 to 2 weeks after injury. Obstructive symptoms include persistent lumbar pain, fever, and anuria. The diagnostic method include intravenous administration of indigo-camine during operation, cystoscopy, ureteral catheterization, and retrograde ureterography, as well as ultrasonography, CT, excretory urography, MRI, and renal scintigraphy. For the differential diagnosis of ureterovaginal and vesicovaginal fistula, retrograde filling bladder with methylene blue should be performed. The principle of management is early repair to protect renal function, drainage of urinary extravasation, for mucosa and submucosal damage, clumping, mild laceration, perforation, dehiscence. Double J standing is enough. For ligation, transection, and segmental injuries, ureterostomy, ureteral reimplantation, autotransplantation of the kidney, ureteral bone interposition might be necessary. For ureteral stenosis, ureteral dilation, standing, a ureterostomy might be required. Ureteral reconstruction or ureteral reimplantation can be used for ureteral fistula. For unrepairable complete obstruction, nephrostomy should be performed, and ureteral reconstruction should be given 3 months later. For severe renal insufficiency, severe hydronephrosis, infection, and with normal contralateral kidney, nephrectomy might be reasonable. The first figure is ureterostomy. The second is proximal ureter is speculated and sutured to the renal pelvis. The third is non-tapered distal ileal segment is anastomosed to the bladder in a wide open fashion. The third is bladder injuries. The etiological factors of bladder injury include penetrating injury, blunt abdominal injury, and iatrogenic injury. Iatrogenic injury might be caused by endoscopic intervention, pelvic, obstetric, and gynecologic complications. Spontaneous rupture may occur in patients with pre-existing bladder disease. Bladder injury can be classified into contusion and rupture. Contusion represents only mucosa muscular layer damage. There is bleeding and hematoma, but no urinary extravasation. Bladder rupture can be classified into intraperitoneal, extraperitoneal, mixed bladder rupture. It can lead to urinary extravasation and bleeding. The patient may have a shock caused by pelvic fracture, abdominal pain, hematuria, dysuria, and azotemia. In extraperitoneal rupture, there might be suprapubic tenderness, lower abdominal bruising, muscle guarding, and rigidity. Digital rectal examination can find mass and tenderness. And in intraperitoneal rupture, there might be chemical peritonitis and shifting dullness. Local signs include swelling, hematoma, and ecchymosis. Penetrating injuries might result in abdominal wall fistula, rectal vaginal fistula if not managed properly. The diagnosis can be made based on the history and physical examination, urethral catheter drainage, bladder filling test, sonography. and plain film or CT cystography, which can show the contrast material actualization. The principle of management is repairing bladder wall, adequate urinary drainage or diversion, complete drainage of urinary actualization. For contusion, ureterocatheter drainage for 10 days is enough. For extraperitoneal rupture, catheterization or bladder repair is required. For intraperitoneal rupture, bladder repair should be performed. The last is urethral injury. The etiological factor of urethral injury include penetrating injury and blunt injury. Penetrating injury consists of penetrating wound in scrotum, penis, or perineum. The bulbourethral injury is often caused by stridal injury and iatrogenic injury. The membranous urethral injury is often caused by pelvic fracture and instrumental damage. Urethral injury can be classified into contusion, laceration, and disruption. Contusion will resolve without sequelae. Laceration can result in hematoma, extravasation, and stricture. Disruption can cause hematoma, obstruction, urinary retention, extravasation, and urethral occlusion. The extent of urinary extravasation is different between the bulbourethral injury and membranous urethral injury. In bulbourethral injury, urine can be limited by callus fascia. Urine extravasate into perineum, scrotum, penis, up to the lower abdominal wall. In membranous urethral injury, urine extravasate into prostatic and perivascular tissue, even retroperitoneal space. If urogenital diaphragm is lacerated, scrotum and perineum can be involved. The clinical findings of urethral injury include blood attenuators or hematuria, pain, dysuria or urinary retention, hematoma, ecchymosis. Urinary extravasation can be found. If there is infection, sepsis, and fistula might occur. Shock can be present in patients with pelvic fracture. The diagnosis can be made based on the history of injury, physical examination, diagnostic urethral catheterization, and retrograde urethrogram. Retrograde urethrogram can define the site and magnitude of urethral injury. For bulbourethral contusion, no intervention or urethral catheterization is reasonable. For laceration, urethral catheterization or urethral repair can be used. For disruption, urethral anastomosis should be performed. Initial suprapubic cystostomy might be standard of care for major stridal injuries involving the urethra. For membranous urethral contusion, no intervention or only urethral catheterization is necessary. For those with unstable hemodynamics, suprapubic cystostomy is necessary. Otherwise, primary realignment of the distraction with a urethral catheter is reasonable. In Figure A, extravasation of contrast medium seen in the scrotum on a retrograde urethrogram in a patient with a stridal injury. In Figure B, retrograde and antegrade urethrogram shows distal limit of urethral patency, but bladder neck does not open. In Figure C, repeat antegrade urogram study showing proximal limit of urethral patency. In the left figure is cystostomy. Number 1 is bladder, number 2 is catheter with retention balloon in bladder, number 3 is catheter, and number 4 is pubic bone. The right figure is operation of urethral realignment. That's all. Thank you for attention.